Okay, welcome back everybody. We will continue our session. Our session, which is called Caught Between Disciplines, Organ-Specific Sarcomas. Sarcomas are very special, as we know, and they're located in the connecting tissue, but sometimes they are in an organ. And then that's why it's called Caught Between Disciplines. The patients end up often with an organ-specific doctor. So that is where, for the second part of this session on soft tissue sarcomas, we focus on these specific organ-specific subtypes. And we have two examples in the breast and in the uterus. But also we have the patient story, and we will start with that. What does this patient experience in this special case? And we have, as a speaker, Marloes van Esterik from the Netherlands, who is a Phyllodes patient, and it's my great pleasure to give her the floor.
Well, like Gerard said, my name is Marloes van Esterik, and I'm very grateful for the invitation to talk to you about the patient perspective and navigating being a patient between disciplines. How do I change? This one? Ah, thank you. This I wrote on I don't remember, was it in a local fundraising at the very beginning of my journey? Because I didn't have so many Phyllodes, we didn't know any Phyllodes patients at the time, I believe. Okay, a little bit about my journey. I've had several lumps removed from my left breast before being diagnosed with Phyllodes. And it all started when I was about 16 years old. And the surgeon who operated on me was a general breast cancer surgeon at the local hospital, and he had encountered Phyllodes before, but I was the first patient with recurrence. And at a certain point, it became a borderline at biopsy. But that was the one time when my regular surgeon wasn't available, and so the surgeon that filled in for him didn't explain anything about what that meant, and he didn't want to remove it. So by 3 months later, it had grown back. It was always like a goose egg on top of my breast. So 3 months later, I had the opportunity to see my regular surgeon again, and he wasn't able to get it all out, unfortunately. Then we opted for a mastectomy, a nipple-sparing mastectomy, and because it reoccurred again, after that they opted for radiation, and my surgeon didn't know why that was, and I asked the radiotherapist where I was referred to, and he couldn't really explain the essence of the radiation. So I got a week to think it over and talk to several specialists, my surgeon, a nurse practitioner, the mama care nurse, the plastic surgeon, my GP, and then decided to go ahead with 16 sessions of radiotherapy, which was in 2016. Since then, I've been clear of phyllodes. Unfortunately, the implant that had been placed had to be removed in 2019 due to other complications, which left me with edema in the breast area up until today. We go to slide 4. I think. Is it this one? Oh, thanks. There was very little info to be found on phyllodes tumors, both from specialists as well as online. But the first thing you see when you search for phyllodes online is like a giant tumor that's cracking the skin, which wasn't the case in my case, fortunately. I was undergoing all these treatments and kind of kept my head down to keep it all together. And my husband was very eager to find out as much as possible. And he was searching and asking around for reliable information. We joined a private Facebook group where phyllodes patients worldwide share information and encouragement. And there we also got in contact with a few local, like Dutch fellow patients. And that was great to meet them, share our experiences, differences in treatments, as well as frustration on the lack of credible information. And Marco mainly channeled his frustration into action, triggered by one instance when I came in for a radiation treatment. And one of the nurses there, who were all very, very kind and very good, but she asked him what the tumor was that I was dealing with, because she had to try to research it as well, and she couldn't find anything. And he was getting so frustrated, like, if they don't know what they're treating here, what is my wife doing here anyway? So that set him off to search online for credible and reliable information, studies and data, putting it all together in a website he built to be found by future phyllodes patients. But to get it noticed and shown, linked on the national cancer websites, it was crucial to have all info on it checked and verified by an oncologist, preferably specialized in phyllodes. And after reaching out to a few well-known cancer hospitals in Holland, he got a response from Dr. Frederike van Duinhoven at the Dutch Cancer Institute, Antonie van Leeuwenhoek, and she took the time to go over his website. And her stamp of approval, as to say, was Marco's first break. And along with 2 other Dutch phyllodes patients, we set up the Dutch Phyllodes Group, and we reached out to the Dutch Breast Cancer Association to get involved. But they responded that we were too rare and referred us to the Dutch Sarcoma patient platform. Before that, I had no idea that phyllodes was somehow related or known to be a sarcoma. So that was my first the Dutch Sarcoma platform was welcomed us very warmly, and they helped us tremendously with their resources and their international contacts. Okay, what we've done, or mainly what Marco has done, we've been creating and distributing phyllodes information flyers to a lot of breast cancer units. We organize patient meetings live and online during the COVID, and some with a specialist joining in for Q&As. We've been writing articles, interviews and columns for the magazine of the Dutch Sarcoma patient platform. We answer questions regarding phyllodes that come in via the Sarcoma helpline or website. We maintain our website in Dutch as well as English, which also included a list of questions to ask a doctor at a consult. Marco has his YouTube channel, and we've organized national and international webinars with specialists from the Netherlands as well as the US. Marco also started fundraising to get research started. And as he's a former baker, he put together his own small bakery in our garage where he bakes his own recipe of baked goods like seasonal sweet bread, savory bread for special occasions and holidays. He had pins and bracelets made to sell for charity, and we organized small music concerts at our home. And all this raised up to now close to 30,000 euros, and he's still going. All the benefits of that go towards the research which has started at the Dutch Cancer Institute in Amsterdam, which is supervised by Dr. Frederike van Duinhoven. And he also joined the task force group to update the Dutch breast cancer guidelines, which now include Phyllodes. And which also, regarding sarcoma, the few sarcoma doctors have reached out and said it should be in the soft tissue guidelines instead of the breast cancer guidelines, but no, maybe it can be at both, since we're juggling both sides. Well, these are a few frequent comments that we hear back from patients, like an optimistic or a too optimistic diagnosis at biopsy. The mental impact of the recurrence is sometimes underestimated. There's little information from specialists. We haven't, well, it's now starting to change, but my general surgeon does have our flyer, so when he encounters new Phyllodes patients, he refers them to us. In case of radiation, most patients here only get to hear the pros and not the cons, only just a little bit of fatigue. There was a big variety in treatment and follow-up, and a standard protocol or guideline was a given for us, like something to hold on to regarding your treatment. It would be, well, it will be very helpful, not just to check all the boxes, but as a frame to go by. And in individual cases, there should be room to add or leave some options depending on the personal circumstances. And of course, we're very delighted that we made that happen in the last year. This concludes my presentation. Thank you.
Thanks a lot, Marloes. Are there questions right now for Marloes? Okay. Oh, yes, one. Please. Yeah.
Thank you. Congratulations, both of you. I think you make a wonderful team. I wanted to ask, and maybe it's that I just don't understand the Dutch healthcare system, but when you asked about the radiation, who'd made that decision? Was it in a multidisciplinary team that they made a decision?
Yeah.
But they couldn't explain why.
Well, from my perspective, I sat across from the radiotherapist, and he said, well, it will reduce the risk of recurrence by 50%.
Okay.
Okay. What does that mean? When it would recur in 2 months, will it now be in 4 months, or will it, you know,
He couldn't give you the specifics.
Yeah.
Okay.
And he couldn't really answer that, but it was advised through a multidisciplinary meeting. Yeah, that's true.
Thank you.
Yeah.
Any other questions? If not, thanks a lot, Marloes. And I think this was a very nice example of your patient journey, patient experience, but also it illustrates what patients can do themselves in organizing information for other patients and also help start up research. Thanks a lot. Okay, we move on to the next presentation by Professor Sanfilippo from the Instituto di Tumoro tumori in Milan, and it's on uterine leiomyosarcoma.
Good morning. It's a pleasure for me to be here today to speak about uterine leiomyosarcoma. Uterine leiomyosarcoma are a very challenging disease for patients and for physicians too. And there are so many issues regarding this kind of disease, and the work to do is still very long and very hard. So, we know that they represent 5% of all soft tissue sarcoma, and we can find in the uterus 4 principal different histology. Leiomyosarcoma is the most frequent disease in uterus. We know that it's a very rare disease, and this is particularly important, it's very peculiar because the benign counterpart of uterine leiomyosarcoma is very, very frequent because it's the fibroids. So the problem for our patients is that the majority of the women has a fibroids, but only a minor part, fortunately, likely, has a leiomyosarcoma, but the diagnosis is often made after surgery. It's a postoperative diagnosis indeed. First, because we don't have a real tool to differentiate fibroids from uterine leiomyosarcoma, because MRI is more specific than other kind of tool, radiologist tool, but is not enough. And we are working on that to understand if we can find a different way to understand before the surgery if a woman has a uterine leiomyosarcoma or not. Because the problem is that sometimes due to the morbidity after the hysterectomy, some surgeons prefer to do the morcellation, and this is an issue if the patient has not a fibroid but a uterine leiomyosarcoma. So the problem is that the diagnosis is postoperative, and in the majority of the situation is a surprise for patients and for the surgeon too. Every day in my clinic, I meet new patients that tell me, "Doctor, they told me that I had a fibroid. What happened? Why I have a different diagnosis now?" And they took 2 or 3 months to have a diagnosis because, of course, if the surgeon thinks that is removing a fibroid, even all the other everything that arrive later can be delayed, even because that patients that undergo surgery are patients that undergo surgery in peripheral center, not in other referral center, because they think to have a fibroid. This is the first problem, so the postoperative diagnosis. The second problem is the diagnosis, because we have the classic fibroid, we have the classic leiomyosarcoma, which is a very high aggressive disease, but we have a gray area called stump, smooth tumor with uncertainty potential of malignant. It means that the pathologist, when look at the disease, is not able to understand if it will recur or not. He says, "I don't know if it is a fibroid or a leiomyosarcoma, because with the criteria that I have, I am not able to classify it as leiomyosarcoma or fibroids." We are working on that, again, even with the support of the Leiomyosarcoma Foundation Roundtable, because in this moment, what we know is that when a stump relapse is a leiomyosarcoma. If it doesn't, it's considered a fibroid. But with the support of other group of research, and in particular with the support of other centers and other pathologists like Paolo Deitos, for example, in Padua, we were able to put together different cases of stump relapsed and treated with hormonal treatment. And what we found? We found that those patients that relapsed after this diagnosis of stump had a different behavior than patients with classic leiomyosarcoma, because they had a time to relapse that was 5 years and not 2 like in classic uterine leiomyosarcoma, because they respond to hormonal treatment. So maybe we are dealing with another kind of disease. So stump is not a uterine leiomyosarcoma when it relapses. At least a subgroup of them maybe are low-grade leiomyosarcoma. So we are working to reclassify this kind of disease, because we have not only a different prognosis for our patients, but even a different clinical approach. Because when disease relapse, we have the clinical trial where patients treated with hormonal treatment didn't achieve any kind of response and 2 months of progression-free survival. It means that hormonal treatment doesn't work in uterine leiomyosarcoma. But if we are able to understand who are the subgroup of patients with low-grade uterine leiomyosarcoma, you can see that the progression-free survival is totally different, and the percentage of partial response is close to be 100%. So again, we worked on that with a global effort, and the work to do is still hard and still ongoing. Anyway, without our pathologists, we wouldn't, of course, able to do that, but this is a multidisciplinary work that we are doing. Switching to the classic uterine leiomyosarcoma, so the high-grade uterine leiomyosarcoma, what we know? We know that the standard treatment is hysterectomy, but we don't have an idea, we don't have an idea what to do to improve the prognosis of our patients. Because when I see a patient with a uterine leiomyosarcoma, I know that the risk to relapse is over 50%. And until today, we know that radiation therapy is not able to decrease the risk of open relapse. And we don't know. We know that radiation therapy is not able, but we don't know about adjuvant chemotherapy. The problem of adjuvant chemotherapy, the activity of the adjuvant chemotherapy or the inactivity of it is an issue that started decades ago. We have some pieces of evidence that it can work. We have some randomized study with some advantage. We have other randomized study without. We have phase 2 study where we have an improvement in the progression-free survival if we compare the result with historical control. And we have randomized study from leiomyosarcoma of the other part of the body, from trunk, for example, or for arms, because you know that uterine leiomyosarcoma is leiomyosarcoma can arise from uterus, but can arise everywhere in the body. So in the high-risk leiomyosarcoma from arm and trunk, we were able to achieve a better prognosis with adjuvant chemotherapy with anthracycline. So the problem is that maybe we have to accept in rare cancer some grade of uncertainty if we compare what the data that we have in rare cancer compared to the other kind of cancer, of course. And this is one of the recommendations of the JARC in the Joint Action on Rare Tumor that we had in Europe and now closed. So this grade of uncertainty and the possibility to discuss with our patient to give or not the chemotherapy has been included in the last uterine sarcoma guideline that we will produce in the next months. This is very important to me to show that for the first time we gathered the oncology community and the gynecology community together to work on this kind of guideline. Because one of the first problems of uterine leiomyosarcoma is that this is a disease treated in part by gynecologists and in part by medical oncologists like me. So, for the first time, we put together the sarcoma domain from Huracan, the ESGO, the European Society of Gynecological Oncology, and the Gynecological Cancer Intergroup. So a global effort to harmonize the treatment of uterine sarcoma. The last meeting was done in Milan, and we included the possibility to discuss about adjuvant chemotherapy with our patient, because we don't have data of definitive data of activity of adjuvant chemotherapy, but at the same time we have some piece of evidence that maybe it can work. If we look at the advanced disease, we have a lot of drugs that we can use with a good tolerability, but unfortunately we don't have new drug. Leiomyosarcoma is a disease where we don't have target. In this moment, immunotherapy is not active. So we are still using the drug that, the last drug, Pazopani, has been approved in more than 1 decade ago. So we really need new drug in this disease. Anyway, we have a new achievement, because you can see in first line the combination of the adriamycin with dacarbazine or trabectedin. Until now, we knew that if we use different drugs in the advanced disease, we can achieve an improvement in overall survival in the end. But no one of these drugs in clinical trial showed a benefit in overall survival alone in advanced disease. But you know that recently at the last ESMO meeting has been presented this French sarcoma group study with the combination of doxorubicin and trabectedin versus doxorubicin alone. And this is the first time that this is the overview of the study, and this is the first time that we achieved a benefit in overall survival in the advanced disease. There are decades again that oncology struggled to show a benefit in overall survival with combined drug in first line, because the problem is that when we combine two drugs in first line for soft tissue sarcoma, for example, doxorubicin plus ifosfamab, doxorubicin plus dacarbazine, of course, we have more toxicity. So when we have to speak with our patients to propose the combination, we need to have on the other side a benefit. This benefit until now was a better progression-free survival, but not a benefit in overall survival. Now, for the first time, if we compare doxorubicin trabectedin versus doxorubicin alone, we have a benefit not only in the response rate and progression-free survival, but even in overall survival, and this is the first time. So we have even the data about the activity of doxodacarbazine. One of the questions in this moment is, do we need a study, a trial, to understand what is the best combination? No, maybe not. We have piece of evidence that both works, and now we know that we can have an improvement in overall survival. Of course, in this study, the combination was not the only things that was offered to the patients, because if we look at the design of the study, a consistent percentage of patients underwent surgery, and we know that the surgery can improve overall survival even in the metastatic disease in patients with sarcoma. We know that the arm with the combination had the maintenance therapy, and we have the previous study where the maintenance therapy showed to achieve a better progression-free survival. So, what is the clinical implication of this trial that was presented a few months ago? That the combination of therapy in first line can give a benefit in overall survival, and this is the first time that we are able to show that. Maybe this is not for all our patients because they need to be fit. The combination has more toxicity, and at the same time we need to be able to propose the whole package. So not only the combination treatment, but even the surgery and the maintenance treatment. So the problem is that you have to select oligometastatic disease, for example, not only patients with a good performance status. So in the end, even in the metastatic disease, sarcoma is a multidisciplinary disease where we have to integrate to the medical treatment with surgery or radiation therapy, and where all the specialists need to discuss, all in the multidisciplinary board, to find the best individualized treatment for everyone. So this is in brief what I wanted to say with my presentation. Uterine leiomyosarcoma is a rare disease. It shows a lot of challenge and issue. The prognosis is still very bad, and it remains a multidisciplinary disease even in the metastatic setting. Thank you.
Thank you very much, Roberta. Are there any questions right now for Roberta? Yes. Please.
Thank you. I just have a short question. I don't hear you mention anywhere there's radiation therapy does not have a place in this disease, or?
Well, not in every setting, in the adjuvant setting. In the adjuvant setting, it is not able to reduce the local relapse. We have some retrospective study where radiation therapy is able to give a benefit in the local relapse, but not in the overall survival. Anyway, we have this big study of AORTC, where patients were randomized to receive radiation therapy after hysterectomy or not. This study did not show any kind of benefit in those patients that receive radiation therapy, not only in the overall survival, but even in the local relapse. Again, this does not mean that we never propose radiation therapy. We individualize the treatment if, for example, the risk of local relapse is higher because the disease was outside the uterus, for example, or again, if the patient has a local relapse. But in this moment, radiation therapy is not an option for patients that that received an hysterectomy for the disease that was only in the uterus because of this study.
Thank you.
Yeah, Roger, thank you.
Yeah. Roberta, thank you. That was, a really nice summary. But the question I have to ask goes back to the diagnostic end of the issue with uterine leiomyosarcoma. As I understand it, there are effectively 3 styles of removal of the uterus. There's a complete hysterectomy, total hysterectomy, THBSO, I think is the common term. There is morcellation, which can be either done microscopically or can be done through an incision. And there is mechanical morcellation, which I think has fallen into some disrepute in recent years. But can you comment on those three and whether the prognosis for patients is different depending on the particular kind of surgery they have?
Well, now is demonstrate that if patients underwent morcellation, the risk of intraperitoneal disease and the intraperitoneal relapse is very high. The problem is that, of course, the morbidity after the surgery is low, and the majority of patients has a fibroids, and this is the best treatment that they can receive. But in case of uterine leiomyosarcoma, we absolutely need to avoid morcellation, because even in those cases that the morcellation was done into the bag, you are not sure that you may achieve the same result with an open hysterectomy. So in this moment, I think that this was understood from gynecologists, and now is rare to see patients that underwent morcellation in my clinic. That's my feeling in the last year.
That at least is positive news.
Yeah.
So that's good to hear. Thank you.
Okay, thank you. Any further questions? No? Thank you very much for your presentation, Roberta. And then we go to the final presentation of this afternoon on Phyllodes, and the speaker is Frederike van Duinhoven from the Netherlands Cancer Institute in Amsterdam.
Better? No, it's the same. This one's better. Whoa. It's too good, it's too good. I don't think it's necessary to speak so loud for me. So I'm a surgeon, a surgical oncologist at the NKI in Amsterdam. I don't have any disclosures. And I would like to just present some facts about the Phyllodes tumor, well, mainly the lack of facts, unfortunately, the guidelines that are currently available, the relevant clinical questions, which I think will confirm what the dilemmas that Marloes has already faced. And then we have done, aided by the Dutch Patient Foundation, research on the Dutch available data, and that led us to make new guidelines, at least for the Netherlands. So Phyllodes tumors, of course, are rare, otherwise we wouldn't be here. They constitute less than 3% of all breast tumors and even less than 1% of all breast cancers. The majority of Phyllodes tumors, fortunately, are benign, but there's a subgroup of malignant Phyllodes tumors. It's between 10 and 20%, and there is an in-between group of borderline Phyllodes tumors. The name Phyllodes comes from the word that means leaf. Well, you see on the left side, I hope that it's sort of a leaf-like pattern that's in a benign Phyllodes. The tumor originates in the periductal stroma tissue, and then when it changes into a malignant tumor on the right side, you see that these ducts are all compressed, so the leaf pattern virtually disappears. This, of course, I will not go into detail in, but to differentiate between the benign, the borderline, and the malignant forms, the WHO organization has defined criteria for the pathologist, but even with these criteria, there is some subjectivity, because terms like none too mild or moderate or marked, obviously it's not a quantitative analysis, but more a qualitative analysis. So there will still be differences between pathologists assessing the tissues. Women aged between 40 and 50 normally present with a Phyllodes tumor. They feel something in the breast. It's usually less than 5 centimeters, and it rarely presents as a bilateral disease. And then, of course, who will be the treating physicians? Is it a sarcoma or is it a breast tumor? Do you go to a sarcoma surgeon who will be used to doing huge excisions and excising out all tumors with a huge margin and radiation therapy and, well, it's quite mutilating or aggressive surgery, at least historically speaking, whereas the breast surgeons normally are inclined to do as little as possible and retain the breast and the breast contour and are much more focused on well, removing only that which is absolutely essential. This will differ throughout Europe, but for the Netherlands, it is deemed a breast problem, so a breast tumor for the breast surgeon. There are guidelines, but they differ hugely. So there are ESMO guidelines, but they are very, very sparse regarding the phyllodes tumor. There's an NCCN guideline, which is on the lower part of the slide, which does give guidelines for both benign, borderline, and malignant phyllodes tumors. There's a French guideline, there's an MD Anderson guideline, there's a Dutch guideline, which until recently only suggests to do a wide local excision. What is wide? How wide? Radiation therapy, who knows? To assess this wide variety in treatment of phyllodes tumor, we've done an international survey to which almost more than 400 clinicians responded, both surgeons and oncologists, so including radiation therapists. And just to show you the huge differences between daily standard clinical practice. Do you think a biopsy is necessary? Well, yes, for like 1 in 5, but only if cytology is not clear. Would you recommend an MRI? Well, yes, for the vast majority. Will the patient be discussed in a multidisciplinary meeting? Even if it's malignant, it will be only discussed in 2/3 of the meetings, or at least following the respondents' questions. Surgery, it's a huge issue of, well, debate in phyllodes tumor. If it's a benign phyllodes, then the majority of respondents indicate that you can accept any margin as long as it's tumor-free. But for the borderline and the malignant tumors, this will change, of course. Well, not surprisingly, if it's a malignant tumor, most respondents will indicate that you need a tumor-free margin, but it's a huge difference if you would say that a margin of 1 millimeter is sufficient or a margin of 1 centimeter. If you do surgery in the breast, well, it's a tremendous difference in terms of impact on the patient's cosmetic outcome and thus quality of life. Axillary surgery is hardly ever done for a benign phyllodes tumor, but still 1 in 5 doctors would do it for malignant phyllodes, even though we know for sure that it does not metastasize to the lymph nodes, but it's being done. Also, of course, causing us unnecessary quality of life effects in patients. As for the radiation therapy, Marloes already indicated that the radiation oncologist couldn't really explain to her why it would be necessary, what were the pros and cons. Well, here you can see in the red and the green boxes that for the benign phyllodes tumor, most respondents would indicate no radiation treatment, but in case of breast conserving surgery, about half of respondents would say radiation is necessary. But half, it's like a coin. So maybe if Marloes would have gone to a different doctor, she would have gotten a different advice. Also for systemic therapy, this is probably not news for you, also given the presentation of Roberta. Unfortunately, there is not really very much in terms of effect of systemic treatment, but still almost half of doctors would indicate chemotherapy for malignant phyllodes tumor without metastasis if it's large or if it's a high-grade tumor. Also, follow-up. What do you do once you've excised and treated a rare tumor? Do you do a follow-up for 10 years because you really don't know what's going to happen? Or do you do it short? Do you need to do follow-up for a benign disease? Well, as you can see here on the slide, the difference, of course, correlates with the level of malignancy, but still there are huge differences. So I think these are well, there will be more, but these are clinical questions that are still unanswered, or at least for most patients. What do I do if I have a benign phyllodes? Do I need to undergo follow-up? Do I need radiation therapy? My phyllodes tumor was borderline. My phyllodes tumor was malignant. Do we need to check for metastatic disease following a malignant phyllodes tumor? After, for example, Malusa's case, how long does she need follow-up and what are we going to look for? These are short answers, but I will, of course, go more into detail into them. And for sure, they are not all based on a high level of scientific evidence. So the margin discussion, I guess that's the most prominent discussion when treating phyllodes tumor. Do you need a large excision or a small one, or tumor positive, tumor negative? There was a systemic review done a couple of years ago by Bogach, and that was used as the basis for the new Dutch guideline. But what you can see here on top of the slide is for the benign, and then you go down to borderline and malignant. And if the blue circle is to the right, then a white margin is better. But once the blue circle crosses the midline, there's really not very much reliability of that finding, but only for malignant tumors in this systematic review. So that constitutes the combined findings of many studies of small series and small patient numbers taken together. Only for malignant phyllodes it seems to be a reliable finding. Following this review, there were more studies published, fortunately. Also not very large in terms of patient groups, and some addressed only malignant phyllodes, others addressed borderline malignant, others addressed benign. But the main message seemed to be, of these most recent studies, that it doesn't really matter that much if you do a huge wide excision, so remove all of the breast or breast conserving surgery with a wide margin, rather than retaining as much as possible of the breast and having a tumor-free smaller margin. And it does even seem that for benign phyllodes tumor, it's not very much important whether or not you have some margin positivity. Of course, we wanted to add our stone to this small mountain of evidence. So with the help of the Dutch Phyllodes Foundation, we were able to do research by analyzing all data from the Dutch pathology register. So we could get all the results from phyllodes tumors in the Netherlands starting from 1989. Of course, that was a huge number of patients. We did not reassess the slides. They were mostly not available anymore, but we just could analyze the reports. So that included almost 2,000 of patients with a benign phyllodes tumor, and we found a local recurrence rate of 6.2%, which more or less is the same as in the majority of reported studies elsewhere. And when the tumor recurs, it happened after slightly less than 3 years. And the majority of patients suffered only one recurrence. I have 2 patients in my practice that suffered like 1, 2, 3, even 4 recurrences of phyllodes tumors, but apparently that is rare, and mostly it's just a 1 incident recurrence. We did see that if you resect with a tumor-positive margin, you have a higher chance of a recurrence. Not much higher, but still 9%, so 1.5 times higher. And is there a risk of starting out with a benign disease, benign phyllodes, and then ending up with a malignant disease? Fortunately, that was only found in 7 out of almost 2,000 patients. There was more upgrading to borderline phyllodes tumors. And those patients that were diagnosed with a malignant recurrence, they were all diagnosed before 2008. And that was before the introduction of the criteria that I've shown previously. So we are not quite certain, of course, if the diagnosis initially would have been correct. Then we continued in a second study with the assessment of the borderline and malignant phyllodes tumors in the same database. So almost 1,000 patients could be included, for which the majority were treated with breast-conserving surgery, especially in the borderline treatment, borderline phyllodes group, who did not receive radiation therapy. And for the malignant patients, the half of them were treated breast-conservingly, and only 18% received radiation therapy, which is rather a low number. We did see, of course, well, not of course, but it confirmed that if you have a malignant phyllodes tumor, you have a higher risk of local recurrence, but still the numbers are not very disconcerting, with a recurrence rate of 13% for malignant and almost 11% for borderline. If you have a higher tumor, there's a larger risk. If you have breast-conserving surgery, higher risk. And for this group of diagnosis, there is an increased risk of tumor recurrence if the tumor isn't resected with a clear margin. However, we did not see a difference for the width of the margin. So larger surgery does not necessarily confer benefit for the patients. Specifically for the borderline tumors, the 10-year recurrence rate was estimated at less than 11%, and they occurred at a median of less than 2 years. None of these patients developed metastasis as far as we could extract from the database, and some of the recurrences were malignant. For the malignant phyllodes tumors, the 10-year recurrence rate was estimated at 13%, and this happened quite fast, after 1 year and a couple of months median. We also found that if you do use breast-conserving surgery, then radiation therapy does seem to confer quite a huge benefit in terms of local recurrence, because the 5-year local recurrence without radiation therapy was almost 20%, whereas with radiation therapy it was 5%. So for the next question, do I need radiation therapy? Well, it depends on where you look, which answer you get. It will in any case be a small series of patients, and you can get the answer you want. So on the one study will indicate, yes, you do need radiation therapy, whereas the other one will say, no, you don't need radiation therapy. So Marloes could have gotten any answer. It would not have been right or wrong, but it would have been better, of course, if the level of evidence, the available evidence, would have been discussed with her. In a meta-analysis, so again, lots of studies combined in a giant heap, almost 700 patients were included, and that showed that the local recurrence rate would be reduced if you use radiation therapy. That would not be a big surprise, since we know that is true for, well, at least for all breast tumors, not, for example, for the uterine leiomyosarcoma, which is why I asked my colleague. So it's not always the case that radiation therapy is beneficial, but it seems to be for borderline and malignant phyllodes tumors. So again, another study from 46 patients, borderline and malignant, no local recurrences if radiation therapy is used. And an analysis from the Rare Cancer Network in France. One of my colleagues there is also active in the International Phyllodes Group, over 400 patients, the majority, of course, benign, but still quite a large group, borderline and malignant, and they found that radiation therapy and negative tumor margin both increased local control. So I think that we can make a cautious conclusion for phyllodes tumors that the radiation does reduce the risk of local recurrence, but as with breast cancer, it doesn't necessarily improve overall survival. As for the guidelines, currently the ESMO guideline doesn't really say anything about phyllodes tumors, but it does address the breast sarcoma, which is a wide group of diseases. Phyllodes could be considered one of those. And for the NCCN guidelines, they state there is not reliable prospective randomized data, but you could consider radiation therapy. So this is what we end up with for the new Dutch guideline. For malignant phyllodes breast conserving, we would always recommend radiation therapy, and for borderline phyllodes or a mastectomy following malignant phyllodes tumors, we would recommend radiation therapy only if there's a tumor-positive resection margin. I already shortly addressed the lack of benefit from systemic therapy. Unfortunately, as far as I know, there are no new drugs available or in development specifically for Phyllis tumor. I think we will follow the sarcoma lead, so hopefully new drugs will be developed, but for now there's no beneficial therapy for metastasized disease. Even though there is response to chemotherapy for those patients with metastasized disease, there is no survival benefit. So then, of course, it needs to be discussed with the patient. What is the quality of life benefit? And, then, for the final issue, the follow-up issue. The things I think one should consider, medically speaking, what are the chances of it recurring? When will it recur? Will it recur as something worse? And is there something I can do about the recurrence? Because obviously it may not be helpful to identify disease that you cannot do anything about. Well, these are the local recurrence rates, as I showed you in the presentation. Obviously, green is for the benign and red is for the malignant. The malignant recurrence after a benign Phyllis tumor is extremely rare, and the time to recurrence are always less than 3 years, and for borderline malignant, less than 2 years. Well, not always, but a mean or median. And if there's a disease, metastatic disease, then unfortunately we cannot offer any beneficial effective systemic therapy. Again, the NCCN guidelines, they say 3-year follow-up with clinical follow-up, so physical examination, and you should consider imaging. So it's not really a very strong recommendation. We have chosen for the Dutch guideline to do no follow-up for benign disease. Of course, if a patient is over 50 years, she enters the National Breast Cancer Screening Program. And for the borderline malignant disease, we advise a 3-year follow-up schedule with quite high intensity with an ultrasound and physical examination every 6 months. And if over 50, screening for breast cancer with a mammography. Since there is no benefit from detecting metastasized disease earlier, we do not advise regular screening for metastatic disease by CT thorax or chest X-ray. Of course, this leaves so many questions unanswered still. And of course, well, not of course, but fortunately, Marco is never gets tired from patient advocacy, and he will now visit our colleague, Dr. Rosenberg, in Chicago. She's very active also in the field of Phyllis, and especially her attention focuses on genetic targets or genetic predisposition to develop Phyllis. And this is, of course, very, very helpful when we try to further the international collaboration in the field of Phyllis research. That was my presentation. I'd like to acknowledge and thank some of my colleagues, and of course, Marco and Marloes.
Thank you very much, Dr. van Duinhoven. Are there any questions? No questions? Okay. Well, I think, as far as I'm concerned, I think the take-home message is that there is still a lot of things unknown and room for further research. I wish you really success with your work and with the collaboration with the patient group. Thank you very much. So I think we are coming, it's exactly the time for the end of this session. I think we had a very nice session. It was the first of its kind for organ-specific tumors, sarcoma tumors, or sarcoma-type tumors. So I think this is certainly something that we have to continue in future conferences. I would like to thank all the contributors, all the speakers, and we will continue after this to the next session of our conference. Thank you very much once more.